Good afternoon, and welcome to Bay State's annual Heart and Vascular Lecture Series. It is wonderful to see so many of you once again, and we welcome those who are new in attendance today. My name is Patrick Schilling, and I am the manager of Bay State's Cardiac Rehab and Wellness Program, located at 3300 Main Street in Springfield. A few reminders before we get started. You can ask questions about today's presentation through the Q&A function, and we'll review as many as possible at the end of the presentation. We also ask that you keep questions pertinent to our topic today. At this time, I would like to introduce Dr. Andrew Goldsweig. Dr. Goldsweig is the director of the Cardiac Catheterization Laboratory and director of the Cardiovascular Clinical Research at Bay State Medical Center in Springfield, Massachusetts. He obtained his medical degree from New York University School of Medicine, completed his residency at Yale University, and his fellowship at Rhode Island Hospital, Brown University School of Medicine. He previously served as the medical director of the Structural Heart Disease Program at the University of Nebraska Medical Center. His clinical practice includes procedures including left atrial appendage, patent foramen ovale, mitral transcatheter edge-to-edge repair, TAVR, and coronary interventions. He has been an investigator in over 14 clinical trials and is chair of the Society for Cardiovascular Angiography and Intervention. He is an editorial board member for Circulation, including catheterization and cardiovascular interventions. He also serves as the AMA CPT panel advisor on behalf of the Society for Coronary Angiography. We welcome you, Dr. Goldsweig, and thank you for sharing this information with us today.
Thank you so much for having me. To those who are here in person, thank you so much for being here in person. To those who are here online, thank you so much for being here online. I'm going to take you today through a talk entitled Minimally Invasive, Maximally Effective. And essentially, we're going to talk about new technologies in the Cardiac Catheterization Laboratory. By way of introduction, let me just put up my relationships slide. This is a picture of a relationship that you may recognize. We, interventional cardiologists and physicians in general, work very closely with industry partners. We have partners who help with research, with device development, with providing therapies. And so it's important just to set the stage that there are industry partners with whom we work that are listed there. Most of the procedures we'll be speaking about today are alternatives to surgery. So open heart surgery is a tried and true methodology. Many people would prefer to avoid open heart surgery if minimally invasive options are available. And open heart surgery is something for which many people are not candidates due to medical illnesses, advanced age, inability to tolerate. So today, we're principally going to speak about transcatheter interventions. Now, when we say catheter, we're talking about a tiny tube that's passed through an artery or a vein under X-ray guidance. You can see here on the screen, we've got a picture of the body showing a catheter being inserted into a vein in the leg and then being advanced up to the heart. Now, the three panels there on the side show a stent being deployed, kind of the prototype or the pioneer of transcatheter interventions, with the idea that you could open up a blocked artery by putting a little mesh tube crimped onto a balloon, put it in an artery, expand the balloon, and deploy the stent to hold open an artery. Okay. We're not going to really talk about that type of procedure today. That's angioplasty, stenting procedures. And those are well established. We do about 1,500 of them a year. But we're going to talk about the next level, new technologies, things that can be done through similarly small tubes in a minimally invasive fashion to treat other cardiac conditions. Okay. I have one more bit of introduction, and I'm going to apologize. I don't want to torture anybody or drag anyone back to a high school anatomy class here, but we're going to talk about different parts of the heart. And so you're about to get your 30-second lecture on cardiac anatomy. Okay, you ready for this? So here we go. Blood enters the heart through veins. If it's coming from the bottom, if it's coming from the lower extremities, the abdomen's coming here. If it's coming from the upper extremities, the head, it's coming here. Okay, so You've got the superior vena cava up there, and down here the inferior vena cava. They meet together in the first heart chamber. That's the right atrium, okay, which takes that oxygen-poor blood and sends it through the tricuspid valve into the right ventricle. Okay. The right ventricle pumps blood through the pulmonary valve, okay, up into the lungs. Okay. Here's the pulmonary artery that leads to both lungs. Blood then is oxygenated, it's bright red, and it returns from the lungs in the pulmonary veins. Okay. The pulmonary veins drain blood into the left atrium here, which pumps blood through another valve, this is the mitral valve, okay, into the left ventricle. The left ventricle is the main pumping chamber of the heart, and it pumps blood out into through the aortic valve into the aorta, which is the main blood vessel of the body. Okay? The aorta then branches, has branches going everywhere. Everywhere you have blood, you have an artery going. Okay? So that's our quick outline of cardiac anatomy. There are 4 valves, 4 chambers. The whole system is a pump with check flow valves, right? Each chamber pumps blood into the next chamber, and a valve prevents flow from going backward. So things that can go wrong are there can be dysfunction of the chambers, there can be dysfunction of the valves, there can be incorrect connections between the chambers, and that's what we'll talk about today. In particular, we're going to talk about 4 procedures and 4 types of pathology or dysfunction. Okay? First, we're going to speak about atrial fibrillation. That's an abnormal heart rhythm that can be associated with stroke. And we're going to talk about a minimally invasive way to prevent stroke from atrial fibrillation. Then we're going to talk about a hole in the center wall of the heart. Okay? And that's called a PFO, or for patent foramen-ovale. And that can also be a source of stroke, and that's something we can close without surgery, again, in a minimally invasive procedure. Now, mitral valve regurgitation, that's a leakage of the mitral valve. Again, something that historically had required surgery. We can treat that with a catheter-based, minimally invasive procedure. And lastly, aortic valve stenosis. That's a blockage. A stenosis is a blockage of the aortic valve. It doesn't open appropriately, and we can actually replace the valve entirely in a catheter-based procedure. So here we go. You ready? Go. Atrial fibrillation. Okay, so the heart has an electrical system. Okay? You're born with a pacemaker. It's in the right atrium. It's in the upper right chamber. Okay? Here it is. And it sends out, as diagrammed by arrows here, electrical signals to each of the other chambers, telling them to beat. Right? So the heart electrically conducts a current, and as each cell gets that current, it squeezes. But what can go wrong with an electrical system? Anybody here ever lost power? Right? So turns out the electrical system can malfunction. Right? Sometimes people need a generator. They need a pacemaker. Sometimes you have short circuits. Short circuits are really common. And so what I'm going to show you here, these little spirals, these are short circuits in the atria. When you get short circuits in the top chambers, instead of all the cells squeezing at the same time, each one goes on its own. Right? There's not an organized squeeze. That's called atrial fibrillation, or AFib. It's a very common arrhythmia. It affects about 25% of people in the US at some point in their lifetimes. Now, who cares about AFib? Well, I'll tell you, you care about AFib. And the reason you care about AFib is that the left atrium has this little projection that sticks forward and to the left, called the left atrial appendage. Right? It sticks forward and to the left there. I'm going to jump to the next slide. I can show you a specimen here. Right? So this is the left atrial appendage. You have one. Everyone has one. We can get together at some point afterward and have a philosophical discussion about why you may have one. I don't have the answer to that. But when the left atrial appendage is squeezing normally, when the heart is pumping normally, it pumps blood like any other part of the heart. But when you have an abnormal heart rhythm, when you have atrial fibrillation, now the left atrial appendage is not squeezing, right? Each individual cell is moving separately, and you have this sock, this pocket of blood, sitting still. You know what happens when blood sits still? It clots, right? And if you form a clot in your left atrial appendage, it can migrate anywhere in the body, and we're particularly concerned about it migrating up top, because that's a stroke. So, as it says here on the slide, AFib increases the risk of stroke by about 5-fold. Okay? So people with AFib have about, on average, a 5 times greater risk of having a stroke than the general population. And within people with AFib, there are risk factors that are associated with an increased stroke risk. And I've put some of those here. But you can see as you accumulate more risk factors, you have higher stroke risk with advancing age, female sex, higher blood pressure, diabetes, and other cardiovascular problems. So, AFib is very common. AFib is associated with stroke. What do we do about it? Well, historically, this is what we did about it. We put people on blood thinners. And we put people on blood thinners lifelong. Right? If you put somebody on a blood thinners are effective. They prevent blood from clotting in the left atrial appendage. But less than 50% of people with AFib manage to take blood thinners regularly. Why? They're concerned about bleeding. Some people have actual bleeding. They have GI bleeding. They have bleeding in their lungs. They cough blood. They have nosebleeds. They have bruising. Some people, it's just about the bleeding risk, right? If somebody has an unstable gait, if somebody has a hobby, they like skiing, right? And they don't want to be on a blood thinner because they know if they happen to hit a tree skiing and they're on a blood thinner, that's going to be lights out. Other issues with blood thinners are common. People have medication issues. There are medication interactions. Some blood thinners are a twice-a-day pill, and I can't speak for anyone else, but for myself, once a day is hard enough. Twice-a-day pill, I'm not likely to be super successful with that. And many of the blood thinners that are on the market now are exceedingly expensive. So even if somebody is able to take a pill, they may not be able to afford the appropriate medication. So what we're going to speak about now is an alternative to lifelong blood thinners, and that's called left atrial appendage occlusion. Okay? Left atrial appendage occlusion means we find that part of the heart, that pocket where blood clots form, and we occlude it, we close it off. Okay? We occlude the left atrial appendage to prevent stroke. And we use a couple of devices for that, which I'll show you in just a moment. But essentially, we put a metal scaffold, a nitinol scaffold with a Gore-Tex membrane over the opening of the left atrial appendage. So here you can see a catheter delivering that device. It's guided by ultrasound. So here is a left atrial appendage. It is sad and lonely. It has no occlusion device. And here is one with an occlusion device. This is what it looks like on X-ray as we're doing it. It's a pretty quick procedure. It takes about 40, 45 minutes, and people frequently go home the same day. The device then, as shown in the bottom panel here, after it's implanted, is covered by tissue, is entirely incorporated into the wall of the heart within about 45 days. Okay? Now, I'm going to jump over here for a second, and I'm going to show you some of the toys. Okay? There are two devices on the market right now for this procedure, two left atrial appendage occlusion devices. Okay? This is the Watchman device from Boston Scientific, okay? And this is the Amulet device from Abbott. Okay? I'm going to go ahead and pass some samples of those around. So you can see, here's a little shot glass. Cheers. You can squeeze those. The devices are both very similar. They're both very good. They're slightly different shapes, and they come in different size patterns, so they fit different people differently. But this is essentially how the devices are delivered. A catheter that's this size, so I like to tell people it's about the size of the writing end of your ballpoint pen. And the device goes inside the catheter. Now you say, Andy, how do you get such a big device inside the catheter? Well, I'll tell you. What I wrote up there on the slide, it says nitinol devices. So we're going to take a break for half a second, and I'm going to do a magic trick for you. And folks, see this? This is a copper wire. Here's my magic trick. It's a bent copper wire. I'll be here all day for questions afterward. Okay, this is a nitinol wire. Okay, ready? Wait a minute, I can do it. No. Okay, so nitinol is a material that has a shape memory. And if you see the word nitinol, nitinol was actually designed, Ni, as a nickel alloy with Ti titanium. It's a 50-50 alloy of nickel and titanium. And it was designed by the NOL, the Naval Ordnance Laboratory, in 1944. Here's the story. I'm going to jump back over here. This is the Watchman device I happen to have in my hand. But nitinol was designed by the Navy because in 1944 they were planning to invade the Japanese home islands. And they expected to need thousands of amphibious assault ships that could withstand quite a bit of battery. So here's the idea. Your ship is sailing from Pearl Harbor to Hiroshima, and the Japanese torpedo your ship. And your ship deforms, and then the torpedo bounces off. Isn't it a great plan? Yeah, it's a great plan. They priced it out, actually. Each amphibious assault ship they built out of nitinol would have been about $80 trillion, and they estimated they needed about 2,000 of them. So they didn't end up pursuing that plan a lot further, but you can make nitinol devices, medical devices, for about $50 out of them. And that's the concept and the technology. So I don't know who has the devices now, but I'm going to show you here on the screen. I can take the device, I can squish it down into the catheter, and when I release it, it jumps back to the shape in which it was cast. Okay? So that's a concept that underlies a number of the devices we're going to be discussing today. Now, back over here, you can see on the screen here, this is what a device delivery system looks like. This is the little pusher you use to push the device out of the tip of the catheter, and here's a device crunched up into the tip of the catheter, right? So you simply deliver the catheter to the left atrial appendage, push the device out, and voila. Now you're going to ask me, Andy, does it work? Well, it does, and I'm not going to show a ton of data, but I'm going to show 2 lines on a graph. This is from a trial called Protect AF. 707 people participated, and essentially 1/3 of them got blood thinners for a 3-year period, and 2/3 of them got a device, got this left atrial appendage occlusion device, and then stopped blood thinners forever. And at the end of the 3 years, it turns out the group that had the device, actually, that's the green group, actually had a lower rate of stroke than the group on a blood thinner. Okay, so it's not just that it works to prevent stroke, it actually works better than a blood thinner to prevent stroke. Now, after such a device is placed, we said the lining of the heart grows over the device, covers it completely. Okay. We put people on medication afterward to prevent blood from clotting on the device during that period. Not blood thinners, but we use antiplatelet medications. Platelets are components of the blood that stick to foreign bodies. And so we use aspirin and an aspirin-like medication called clopidogrel. So you stop blood thinners immediately and forever, but after the device is implanted, you do 6 months of clopidogrel and aspirin, and for people who have trouble with that, it's possible to do a little bit less, and then end up just on a baby aspirin, 81 milligrams, teeny pill, after that. Okay. So what we've just presented now is left atrial appendage occlusion as a technology, as a concept, to prevent stroke and atrial fibrillation. Medicine is never static, and particularly at Bay State, we're very fortunate to be leaders in this field and to participate in moving the field forward. What I'm going to say now is a preview of the future. What I'm going to show you is not FDA approved, and I'm going to look for it here. The devices that are going around that you saw are round, and they come in 14 sizes. But people are not round, and people don't come in 14 sizes. People are all sorts of shapes and come in all sorts of sizes. So Conform is a novel device, and it's a novel trial, and I'll show it over here. This is the Conform device. It has a nitinol skeleton. There is kind of an endoskeleton that's made of nitinol, but the device itself is made of a gel foam, right? It's like a sponge. And so the minute this gets wet, it expands like a sponge to fill whatever it's in. This device, when you put it in a left atrial appendage, what shape and size it assumes are the shape and size of the left atrial appendage. So this device is designed to fit everybody's anatomy differently and uniquely. Now, this device is not commercially available. It is currently part of a clinical trial that we're participating in, and it's comparing this device to either the Amulet device or the Watchman device. Okay, so that's ongoing. Okay. It's also worth saying that there's no exposed metal here, and so the thought is that tissue will grow over it even faster. So you may not need the antiplatelet agents for a full 6 months. Okay, so that's left atrial appendage occlusion in a nutshell. We're going to have a full stop, new thought, and we're going to move on to a different topic now. Okay? It's related because we're going to keep talking about stroke. We're going to talk about what if you have a hole in the wall of your heart. So it turns out that's also pretty common. Right? A PFO, or patent foramen ovale, is a hole that connects the two atria, the top two chambers, and about 25% of people have one of those. It's congenital, you're born with it. Okay? They come in different sizes and different degrees of severity, but here's how that looks. So this is a little bit of embryology for you. Essentially, you have one primitive atrium before you're born, and a flap of tissue grows from the top, a flap of tissue grows from the bottom, and they're supposed to meet. And you know what? Sometimes they don't. The way we diagnose that is with an ultrasound, an echocardiogram. Essentially, during the echocardiogram, you inject some bubbles, just some shaken up saline, into an IV. And if those bubbles cross from one atrium to the other, from the right atrium to left atrium, there's a hole there. So let's see if I can make this play. There we go. So you can see bubbles on the right side, and immediately they cross to the left side. And for your convenience, that will play over and over again until I click to the next slide. So this is called a bubble study, and it diagnoses a hole between those top two chambers that's called a patent foramen ovale, or a PFO. Again, present in about 25% of people. Now, why is this a problem? Who cares? I'll tell you why you care. We all form blood clots in our legs. The only thing that drives blood from your legs out of your legs is when you flex your leg muscles. So when you get up and walk, you'll move the blood out of your legs. But when you're in a conference room, eating vegetarian chili, hearing some cardiologist blab about patent foramen ovale, you form some teeny blood clots in your legs. And you know what? It doesn't matter. Because the minute you get up, a 2-millimeter blood clot, who cares? It comes up through your right heart to your lungs. Your lungs are large, there's plenty of redundant space there, and your body's native clot busting system breaks it down very rapidly. Okay? But here's why you care. Because a blood clot from a vein, if it crosses a PFO, can end up in the arterial system. Now, a 2-millimeter blood clot is nothing in the lung, but a blood clot from the vein that crosses to the arterial system can go to the brain. The arteries that feed the brain are 1.5, 2 millimeters. And so once you get a blood clot in an artery in the brain, there's a real stroke risk. So when somebody presents to the hospital with a stroke, and we find that they have a PFO, a patent foramen ovale, we offer to close it. Okay? Now, closing a hole in the heart can sound like something very scary, but the good news is that's actually about half an hour procedure, and they go home the same day. So let's talk about that for a second. See if we can find some devices. There are two devices on the market available for that, and I'll show them right here. Okay. Grab a catheter, actually. This is the Amplatzer PFO occluder, and I'll pass one of those around. I'll also pass around a Gore Cardioform PFO occluder. They're both very similar devices. The Gore one happens to be implanted on a silicone septum here, for what it's worth. So these devices are deployed through a catheter that's even smaller than the left atrial appendage catheter. Okay? And actually, maybe what I should do here is point to the model over here, and then I'll jump back there. So you can see here's a PFO in our picture on the screen. The catheter is advanced across the PFO, and a disc is extruded from the catheter on the left atrial side. That disc is pulled back flush with the wall, and then the second disc is extruded on the right atrial side. So that's how the plug holds in place. Okay? The discs are bigger than the hole. And within about 30 days, those discs are covered in tissue. You can see here, 5 counterclockwise turns releases the thing from the catheter. So people tell me that this is more of a dramatic portion of the procedure, but if you see the device here, it fairly easily and effortlessly goes into the catheter. You can push out one disc, pull it back against the septum, and then push out the second disc. Okay? So that's PFO closure in a nutshell. I'm going to put that down for a second. Now, like the previous topic, you're going to ask me, Andy, that's cool. Does it work? It does. So RESPECT, what that means to me is one of the largest cardiovascular trials that was conducted over a 10-year period. So they, in respect, they enrolled almost 1,000 people, and they followed them for 10 years, which is just a real tour de force in terms of clinical research. And they took people who'd had stroke and who had a PFO. Half of them, they gave antiplatelet medications, like we discussed earlier. They gave them 2 antiplatelet medications for 10 years. And half of them, they closed the PFO and gave them 30 days of antiplatelet medications. And you can see here, the group that had PFO closure was much more likely to be free of stroke than the group that had medical therapy with no PFO closure. Okay? So really effective at preventing stroke. So you say, Andy, that's great. PFO closure, it's a great way to prevent stroke. Is the story over? No, it's not, because as we mentioned earlier, we are part of some major research trials. And so there is a lot of motion in this space. So I'm going to show you, again, disclaimer, this is not an FDA-approved device, but part of a big international research trial. And I'm proud to say that Baystate actually is the #1 participant right now in this trial. This device is part of the Occluflex trial. So this device is being compared to either of the other 2 devices, which I should be passing around. Let me pass those around. Here's a silicone septum with the Gore device and an Amplatzer device. So the novel device, this device, the Occluflex device, has a couple of interesting design features. First, the braiding of the device has been improved. So as a result of, honestly, just geometric braiding technology, they did some fancy math and figured out how to braid it better. This device uses 40% less metal, so it's much more likely to grow tissue quickly. Okay? It also has, you see this fancy gold color, it also has a titanium coating on top of the nitinol. So for people who have nickel issues, people who are nickel allergic, this device is safe. And lastly, on top of the titanium, there's a collagen coating. So it's supposed to be especially biocompatible. Essentially, this device should grow tissue really, really fast and be incorporated into the wall of the heart really, really fast. The last thing that's novel and exciting about it is the delivery system. So I showed you on the other devices that they screw onto the delivery catheter, and that means the device is always at some sort of angle from the catheter. It's under some tension from the catheter. Whenever you release the device, it snaps into position. This device doesn't happen because it's got a ball and forceps joint. So as I kind of rotate it here, you can see it rotates around the tip of the catheter. It can assume its permanent position before you release it from the catheter. So it's a small incremental improvement, but it is exciting to see the field moving forward, and it's exciting to really see it moving forward at Baystate. Okay. What do you think we're going to find next? I'm a little excited. Anybody? What do you think we're going to find next? Uh-oh. It's a pop quiz. Okay, I'm going to need some help with this. Which of the following is not the brand name of a new cath lab device? Is it Watchman, B, Amulet, C, MitraClip, D, Sapien, E, Core Valve, or F, Zap Band? Anybody? Anybody for A? That's not the name. B, Amulet. I just passed a Watchman and an Amulet around. C, MitraClip. D, Sapien. People are thinking Sapien, though, that's an organism, right? Core Valve? How about Zap Band? Okay, well, it turns out Watchman is the device we passed around for the left atrial appendage. Amulet, the other device we passed around for the left atrial appendage. We will soon speak about MitraClip for mitral valve repair. And the Sapien and Core Valve devices are both aortic valve replacements. But the Zap Band was an electro-funk band from Hamilton, Ohio from 1977 to 1999. And I personally don't implant those in people. Okay, we're going to move on now to talk about mitral valve regurgitation. Okay, we're going to talk about two valves, first the mitral valve and then the aortic valve. Those are the two left-sided heart valves. Okay. And when we speak about the mitral valve, it's important to understand its anatomy a little bit. So I'm going to just give half a second to the anatomy of the mitral valve. The mitral valve is formed with two leaflets that touch each other, and so blood can't go backward past it. Okay? What keeps those leaflets from just flipping, from prolapsing, from folding backward, is that they're tethered. They're tied down with little strings, little cords that hold them to the heart muscle wall. Okay? So, it's a complex structure, which means there are multiple things that can go wrong. One thing that can go wrong is that some of those little cords can tear. Right? And that's a reasonably common thing that happens with wear and tear and aging. And if that happens, people get mitral regurgitation. They get valve leakage. We call it primary mitral regurgitation or degenerative mitral regurgitation. The valve's broken, right? Those strings, those cords that hold down the leaflet are torn, and the valve leaks backward. But what if you have a totally normal valve, but you have a heart attack? And this area of the heart muscle dies, scars, expands, pouches out. Now you have somebody with a normal valve, but remember the valve is tied to the heart muscle. So this person ends up with functional mitral regurgitation or secondary mitral regurgitation. So this isn't a bad valve. This is a bad heart muscle that's pulling open the valve and holding open the valve. Historically, primary mitral regurgitation, bad valve, was something you could fix surgically, right? Open heart surgery by repairing the valve. But secondary mitral regurgitation couldn't really be fixed surgically because the problem wasn't with the valve. The problem was with the heart muscle, right? That was pulling the valve open. Fortunately, we have one technology now, it's a catheter-based technology that can address both of these pathologies by pulling the valve closed. I'm going to show you that now. It's called mitral transcatheter edge-to-edge repair, and here's how it works. Any type of mitral regurgitation, whether it's a bad valve or a bad ventricle pulling the valve open, the final common pathway is the two leaflets aren't touching each other, right? So the simple solution is to make the two leaflets touch each other. Okay? So shown here, we see a leaky valve and two leaflets that aren't touching each other. A catheter comes up from the vein in the leg to the valve, and it has a clip on it. That clip captures each of the two leaflets, right? And you can see that here. It captures them and pulls them together. Then, when the heart squeezes, the leaflets are touching each other. There isn't leakage. But when the heart relaxes, you have a double orifice valve now. You've got two parallel valves. Okay? So that's the mitral transcatheter edge-to-edge repair procedure, and that device is called MitraClip. Okay? I'm going to show you here the MitraClip that I'm about to pass around. Okay? When it's open, you'll see that there are grippers that grab onto each of the leaflets and then pull them together. The one I'm going to pass around is closed. It's been locked. And once the lock is deployed, there ain't no way to undeploy it. So that's a forever thing. I'm going to pass around a MitraClip. Super small, careful not to drop it in your chili. The MitraClip is delivered with this catheter. Okay. And I can show you this catheter here. So this is a catheter with a MitraClip on the end of it. And essentially, the catheter has these knobs here. This is the great thing about interventional cardiology is you're working in space. There are only 4 ways you can go. There's an anterior and a posterior knob, which bends it forward and backward. And there's a medial and lateral knob, which bends it left and right. Okay? The procedure, the complicated part of the procedure is this clip can be deployed and released and deployed and released and deployed and released many times. So ultimately, you want to get the clip on the valve in the middle of the area of worst leakage. And so the procedure can take half an hour, or it can take 4 hours, depending on how long it takes you to get the clip right in the right place. Right? You deploy it, you look, did I make it better? I wish it were a millimeter to the left. You release it, you move it a little bit. No, that's too far. And you do it iteratively until you get it in the right place. Okay. Here's what it looks like when we're doing it. So this procedure is guided by ultrasound, and here you can see these are the valve leaflets. Okay, one valve leaflet here, not meeting the other valve leaflet here. And these are the two clip arms as the clip is being delivered to the valve. Here's what it looks like on X-ray. And you see why the ultrasound's important, because you can't see the valve on X-ray. And then here's the super close-up zoom in of the clip, so you can see this is what's being passed around. So one leaflet goes here, captured by this gripper. The other leaflet goes here, captured by this gripper, and then the whole clip pulls them together. I know what you're thinking. Andy, does this really work? It's a theme, right? So it does, it turns out. And then here are the data. Okay? The trial was called COAPT, and COAPT enrolled 614 people, and essentially compared them to half of them getting the device, having their valve repaired, versus having just maximum medications. And they followed them for 2 years. The numbers that come out of this trial, I think, are really striking. You can see how far apart these lines are. The rate of hospitalization was cut in half with the device versus maximum medication, and the rate of death was reduced by more than a third. Now, when we talk about interventions that reduce death by more than a third, I'm a big fan of vaccination, right? I've had 5 COVID vaccines. Everyone should have one. But how many people do you think you need to vaccinate against COVID-19 to prevent a death? A lot, right? 50,000, 100,000. How many MitraClips do you need to deploy to save somebody's life? 3, right? So very, very efficacious procedure, really, really effective, especially compared to a lot of the interventions we consider standard of care, where you have to do a heck of a lot more of them to save a life. Okay. Uh-oh. Hate these pop quizzes. Okay. How many years, this is social. How many years of post-high school education does it take to become a structural heart disease cardiologist? Anyone? 12? 16? 8? Okay, well, it does take 16. You do your 4 years of your undergrad, and then your 4 years of your medical school, and then your 3 years of general internal medicine residency, and then your 3 years of cardiology fellowship, and then 1 year of interventional cardiology fellowship, and then 1 year of structural heart disease fellowship, which gets you to 16 years. I was fortunate to do 2 additional years of research training, which got me to 18 years, and I started my first job when I was 36. I'm not that old. Although some of this stuff really makes the hair grayer around the temples. Okay, I'm going to speak about one more procedure, and that's going to be to address aortic stenosis. Aortic stenosis is one of the most common heart valve problems. It's a problem with aging. And here in the picture, you can see this is an aortic valve. It's a very diseased aortic valve. So when we're born, the valves are 4 or 5 cells thick. They open and close like little wisps of angel hair. And then they get subjected to heartbeats. And we have about 1 billion heartbeats per decade of life. So when you get to be a member of the 7, 8, 9 billion club, you've banged those things together enough that they get fibrous, they get thick, they get calcified, they get scarred, and they look like this. As a result, instead of opening like angelic wisps, right, they're much stiffer, much more rigid. They don't open much at all. And the heart has to squeeze extra hard to get them to open. And over time, the leaflets get stiffer, they open less, the heart has to squeeze even harder, and at some point, the heart just can't compensate. It can't squeeze hard enough to get enough blood through that blockage. Right? And that's what's really shown in this diagram here. This is not new knowledge. This actually was published in 1968 by Ross and Brownwald, showing that over time, people compensate just fine, but at some point, they can't get enough blood through that stiff valve, and they develop symptoms. They develop symptoms of shortness of breath, chest pain, syncope, fainting, can't get enough blood through the valve. And when they develop symptoms, that's a suggestion that they really have heart failure. The development of symptoms is associated with the onset of death. Once people develop symptoms from aortic stenosis, the average life expectancy is about 3 years, okay, untreated. Now, can you give people medication? Well, you can give people medication to treat symptoms, right? You can make people's breathing a little bit better. You can give them medications to get fluid off or to lower the blood pressure to improve forward flow. But ultimately, the mechanical problem, there's no Drano you can give people for the valve. if you go to a physician and he says, oh yeah, just try a little Drano, find a new doctor. Now, historically, surgery was the option here. And open heart surgery is certainly available to treat aortic stenosis. The big problem is that this is a disease of aging. And so the average individual who has this is somewhere between late 70s and mid 90s. And there aren't a lot of cardiac surgeons who get really excited when an 88-year-old walks into the office saying, how about some open heart surgery? And there aren't a lot of 88-year-olds who think, gosh, yeah, that might be fun. So, transcatheter aortic valve replacement. Okay? Usually the acronym is pronounced TAVR. Okay? And I'm going to show you two devices. This is the SAPIEN valve. Okay? And it's delivered on this catheter, which made it to the bottom of the pile. Okay? So catheter is identical in size to the catheter we use for left atrial appendage occlusion. Okay? And you can see the end of the catheter has a balloon on it. So what happens is the valve prosthesis is crimped onto the balloon. The whole system is advanced through the artery in the leg up to the heart, and then as shown in the diagram here, the balloon is inflated and the valve is deployed. The balloon is then deflated, the valve stays where it is, and the whole system is removed, and this is what's left. Now this is a plastic model. I will warn you, it is a piece of injection molded plastic. It has seen better days. Try not to break it any more than I've already done, but that'll go around. And then I can hold the valve up here. This system really has a very simple control. The knob in my hand here just flexes the whole catheter to bend it around the aortic arch to position it in the heart. Okay. So that's that one. Let me unbend it. Let me show you what that looks like in the cath lab. Okay. In the cath lab, here you see with the X-ray images, this is the valve crimped onto the balloon, and when the balloon is expanded, you can see the valve being deployed here. This is a super close-up of the valve. So you can see the valve itself is a stent frame, a metal mesh. It's an alloy of cobalt and chromium. Okay. And it has 3 leaflets here. They are shaped exactly like human leaflets. They're manufactured from bovine pericardium. They're manufactured from cow tissue. It is not a cow's valve. Cows are bigger than we are. If you get this valve, you don't say moo. But it's animal tissue that's used to make a human valve. The valve also has a skirt around the bottom. Why? Well, we're classy like that. And also because we know that there are chunks of calcium around that native valve, and we don't want leakage next to one of those chunks to come around the valve. So the skirt is like a pillow, and it really fills in the area nicely around the valve to seat it well and prevent any leakage around it. Okay. Now, this is a space where there are multiple devices available, and this is the competing device from Medtronic. This is the core valve. Core valve is made of nitinol. I know we passed around the nitinol left atrial appendage devices earlier, and I did my fancy nitinol magic trick. This valve gets crunched down, and I can crunch it here, but this valve gets crunched down into a catheter that looks like this. It's the same size as the other catheter. And maybe I'll pass around the core valve as I say it. The actual core valve has pig tissue leaflets. This one has synthetic polyester leaflets, just as a sample. But the concept here is that if you see the head, the nose cone of this catheter, the valve is crunched into it, and it's a nitinol device. So as I turn my hand here, I unsheath the valve, right? And the valve flowers and expands on its own. Now, that's shown here in the orange portion of the diagram. You can see as you unsheath the valve, it flowers and ultimately is released. But before it's released, the entire valve portion is out. And so that's what's shown here in X-ray in panel A. Once you get to this point, the good news is the valve is functioning. It's absolutely working. And so you can look with an ultrasound and with your X-ray and say, hey, is it in the right place? Is it working right? And if it is, great. Then you finish unsheathing it, as you see in panel B, and release it. But if it's not, if you say, gosh, I wish I had it a little bit deeper or a little bit shallower, as they say, NBD, no big deal, right? Because you can simply turn the catheter the other direction and recapture it, right? And then once you recapture the valve, you can redeploy it over and over and over again if you need to until you get it where you want to. Okay? So the exciting thing, the advantage of the core valve may offer is that you get a second chance and a third chance and a fourth chance if you want to get it exactly how you want it. Okay. Now you've been through this before, right? I know what you're going to ask me. Does this really work? Yeah, it does. And there have been a lot of trials of this one. I'm not going to go through all the details in all these trials. You can see that there are a bunch of red and blue lines. And suffice it to say that there have been trials done in people who are absolutely not surgical candidates. And transcatheter valve replacement is better than medical therapy. And it's been done in people who are high risk for surgery. And transcatheter valve replacement is better than surgery. And it's been done in people who are at intermediate risk for surgery. And transcatheter valve replacement is better than surgery. And it's been done at people who are very low risk for surgery. And it turns out transcatheter valve replacement is better than surgery. So transcatheter valve replacement at this point has really become the standard of care. If you come in with a blocked valve, you're going to get a transcatheter valve unless you've got some other reason. Okay. Now, transcatheter valve replacement is also a lot easier than surgery, right? Surgery, big open heart surgery, takes 6 hours. You're in the hospital for a week. You feel like a train hit you for a month. Transcatheter valve replacement is a much easier deal, right? You're in the hospital overnight, the procedure takes an hour. So what if you don't have the most severe valve blockage? What if you have a moderate valve blockage? Well, in the era when valve replacement was really a big deal, open heart surgery, long time in the hospital, you wouldn't think about replacing a valve in somebody who didn't have really severe blockage. But now, it's a reasonable question. And it's being asked by a major trial in which we're participating at Bay State. And that trial is called Expand TAVR 2. Okay? Again, off-label, not FDA approved, right? This technology is approved for people with severe valve blockage. But what if you have a moderate valve blockage? Okay? And that's diagrammed here showing nozzles blocking flow from a hose. We know if you have a severe blockage, right? If your valve is less than 1 square centimeter, valve replacement, transcatheter valve replacement. But you know why 1 square centimeter defines a severe valve blockage? Because it's a round number, right? It's not like God came to Moses and said, 1 square centimeter shall define. So like that didn't happen, right? 1 square centimeter is just a round number. So if you have a valve area that's 1.2 and you're short of breath and full of fluid and struggling to walk, let alone go upstairs, maybe you'd benefit from valve replacement. And that's what the Expand TAVR trial is all about. It's treating people who are symptomatic despite maximum medical therapy, and it compares the current standard of care, the previous standard of care, which is maximum medical therapy, to valve replacement plus maximum medical therapy. So we're very fortunate that not only do we have some really exciting therapies to offer, but we have exciting therapies and exciting trials that are bringing these to more and more people who may benefit from them. Okay. They tell you you're supposed to say what you're going to say, then say it, and then say what you said, right? So this is what we talked about. We talked about left atrial appendage occlusion for atrial fibrillation to prevent stroke, right? Those are those devices that plug the hole in the heart if you have AFib so that you don't need to take a blood thinner ever again. We talked about PFO closure, okay? And that's closing a hole between the top 2 chambers of the heart to prevent a blood clot from going through and causing a stroke. We talked about MTR, or mitral transcatheter edge-to-edge repair for mitral regurgitation. That's to prevent leakage of that valve. And we talked about TAVR, transcatheter aortic valve replacement, for aortic valve stenosis, for blockage of that valve. My final slide, I always like to put a picture of 2 of my favorite assistants, who may or may not be sitting in the front row. So it's really a great honor and pleasure to speak with everybody today. I would be happy to take any questions. And also I'll point out all of my contact information is on the slide. So feel free. I'm really excited about this stuff. If you want to email me, call me, text me, come visit me, we're happy to talk to you and let you know more.
Thank you very much, Dr. Goldsweig, and for this wonderful topic today. I'd just like to ask for a round of applause for this wonderful presentation. I learned a lot and truly fascinating. At this time, I'd like to open up the floor for questions that people may have. So if you have a question, please raise your hand and we'll distribute the microphone. Okay.
It obviously took a long time to develop this, okay? It obviously took a long time to develop this. How did they go about developing it? Okay, were there a lot of injuries along the way?
Yeah, so in general, the way these interventions come about, you look to people first who have no other option, right? So let's talk about transcatheter valve replacement. The first person who had a transcatheter valve replacement was somebody who was far too sick to have surgery, couldn't get him out of the hospital, right? He'd been in the hospital for months and months and months, florid heart failure, full of fluid, couldn't breathe, right? It was clear he wasn't going to make it much longer. The concept was developed of transcatheter valve replacement. It had been tested in animal models. And the initial investigators approached this man and said, hey, look, you don't have much to lose. Would you be willing to try it? He said yes, they did it, and he did well. So a trial was designed to look at people like that, to look at people who are totally not surgical candidates, right? And after transcatheter valve replacement was proven to be better than any medication, they moved into comparing it to surgery, right? You take a large group of people with disease, you randomize them to surgery or valve or transcatheter valve, and you follow them for a couple of years, and it turned out the folks who got the transcatheter procedure did better. So you said, okay, well, what about lower risk people, right? And so the process, the first transcatheter aortic valve replacement procedure was performed in 2003, and it reached the low risk patient population. The low risk trial finished and reported results in 2019. So it was a 16-year process. In fact, it almost immediately paralleled, yes.
So if you're in the study and you're at the higher risk, did the people who were going like the medical way, did they get the option of going to the device way part way through so they didn't have to end up at those higher numbers?
Yeah, so are we talking about valves now, or?
You showed that one of them had, a really bad rate and the other one was flat. And I'm thinking, if I was in that study partway through, I'd go, well, put me down here, don't keep me there. And did they have that?
Yeah,
did
so
they
the
have
way
that
any
option?
study works is that there's something called a data safety monitoring board. So if a study turns positive, if it shows that there's a difference between the two groups, that one therapy is better than the other, the Data Safety Monitoring Board meets, for most studies, usually every month. And if they find out that, the study's not done yet, but one therapy is better than the other, the study is immediately terminated and everybody is offered the superior therapy, right? So that's kind of the way these clinical research pieces work. Now, in subsequent development of new devices, so for example, we talked about the PFO devices. I showed you this new Occlutech device, right? So these two devices, can I get them both up? These two devices will both definitely close a PFO with no problem, right? And with pretty much 100% success. So how does a device like this, how does a trial like that work? What can they look at? Well, the answer is this trial will enroll 450 people, and probably none of them will have a stroke, right? So there's no way to demonstrate that this device is superior to this device. You can just demonstrate that it's not inferior, right? But those trials are much simpler, and honestly, they're much simpler as a physician to enroll people in because you can tell people, look, at the end of this trial, everybody's gonna do just fine, right? The purpose of this trial is to make a small iterative improvement on the device, okay? So this one will grow tissue faster, so you need medication therapy for a shorter period of time. This one is easier to deploy, things like that. But the major outcomes, things like stroke, right? We expect that nobody in this trial will have a stroke.
Going back to the AFib, can I describe a situation? So the patient's in the hospital for a couple of weeks, getting Lovenox, goes home, next morning has a double pulmonary embolism, tiny, no impact on the heart. Put on, and because it's considered non-provoked, put on a blood thinner for 6 months, then it's done. Years later, 5, AFib happens, off to the hospital, there's a blood clot. AFib returned to normal before they had to shock the patient, but then put on blood thinners. So also bilateral pulmonary. So is the clot coming from the legs going through the heart to the lungs? So in other words, in order to get a clot into the lungs, it has to go through the heart.
Yeah, so
So then with that procedure, that would block any clot from going from the legs into the lungs or from the heart into the brain. Is that correct?
so no, so that's a good point. So AFib, atrial fibrillation, is definitely associated with stroke, right? Blood clots in the left atrium, the left side of the heart, and can travel anywhere in the body. Blood clots in the leg travel through the right side of the heart to the lungs. So if somebody has a pulmonary embolism, that's a different mechanism than a stroke from AFib. Now, this is not something I showed today, but just as we can put a plug in the left atrial appendage to prevent stroke from AFib, if people can't take blood thinners, we can put a filter in the inferior vena cava, in the main vein coming from the legs, and that filter has a meshwork to prevent clots from coming up. So for people who can't take blood thinners, there are therapies as well to prevent clot from the legs from reaching the lungs, but it's a different therapy. Yeah, so the short answer to your question is yes and yes. People with significant clotting disorders, the filter can eventually become clogged. Ultimately, those filters are removable. So frequently you'll if somebody, let's say, has an injury and they can't take a blood thinner for a year, you'll put a filter in, and a year later you'll bring them back and you'll take the filter out and put them back on a blood thinner, right? So that's an option for filters. A left atrial appendage closure, though, the tissue grows over that, covers it completely. The left atrial appendage itself is no longer a cavity within about 6 weeks, right? It's gone. If you don't have a reason to avoid blood thinners, it may be simpler just to take a pill. A lot of people have intolerances. Either they really just can't tolerate the pill, they have bleeding issues, or they have an active lifestyle and they're concerned, they're afraid of a lifelong blood thinner, in which case, yes, those are options.
I have a couple more questions in the room, and then I have about 4 questions online, so I'll bring it over here.
How much vigilance is required if you've received a diagnosis of trivial mitral regurgitation?
None. So the 4 heart valves, right, they're leaflets coming together. The mitral and tricuspid valves are physically mounted between the 2 chambers, right, between the right atrium, right ventricle, and left atrium, left ventricle. So those are moving structures. Those leaflets never coapt perfectly, and mild or trivial mitral and tricuspid regurgitation are normal. There's almost no one in the world who has no mitral regurgitation. So if you see a report and it says, oh, there's mild mitral regurgitation, congratulate yourself, you're normal. At least your mitral valve is normal. I don't want to extend that. Yes.
So you were discussing aortic stenosis in the severe range.
Yes.
And that the effectiveness for the transcatheter valve replacement for people in their 60s, 70s, and 80s is very effective. what about somebody that's like 53 that might be on that younger side?
Yes.
And then what would be the difference between kind of that transcatheter valve and then the mechanical valve and kind of pros and cons?
Fantastic question. So tissue valves, we talked about bovine tissue and porcine tissue, cow tissue and pig tissue being used in valves. Like human valves, like your native valve, tissue isn't forever, right? As that tissue slams together, the tissue will eventually break down. And so a tissue valve replacement can be expected to get you 10 to 15 years on average. So if you have somebody who is 80 and you put in a tissue valve and they get 10 years out of it, and then it starts to get narrow again, you can put another tissue valve right inside it. And maybe that'll get them to 95. Right? For most people, that's pretty good. If you're 50, and I say, I have 2 tissue valves, but they're not going to get you more than 30 years, valve, and then 15 years later, another valve. If you have nothing else wrong with you, if you have nothing that's going to kill you in the next 30 years, probably a tissue valve isn't the right answer for you. So for younger people who are expected to outlive not just 1 valve replacement, but outlive 2 valve replacements, a permanent solution is a surgically placed mechanical valve. Now, a mechanical valve is made out of metal, right? Usually stainless steel. That'll last 10,000 years, far longer than you'll need it. The disadvantage of a mechanical valve is it requires you to be on a blood thinner to prevent blood from clotting on it. But the advantage is it's a one and done, right? Mechanical valve is forever.
I have a question on atrial fibrillation. I'm not sure if this is in your specialty, but the question is, why are first cryoablation and second radiofrequency ablations done differently?
So that falls under the realm of cardiac electrophysiology. So I don't do ablations, but cryoablation essentially looks to ablate, looks to damage the abnormal electrical circuits in the most common location where they occur, okay, which is at the pulmonary veins, at the veins that bring blood from the lungs back to the heart. Radiofrequency ablation can be done at those sites, but also can be done anywhere else. So if somebody has had an ablation and they have recurrent AFib, you can map all the abnormal electrical circuits and zap them with radiofrequency ablation.
Thank you. Another question online was regarding PFOs. What would happen had a PFO and it's not closed?
So the challenge with PFO is that it's super common, right? About 25% of people have some degree of communication between those top 2 chambers. So if we closed every PFO in the world, there are 8 billion of us here on the planet, so that's about 2 billion PFOs. I could do nothing all day, every day, but close PFOs and not even make a dent in the number of PFOs out there. The key thing with PFO is identifying people who will benefit from it. So what we know is that if somebody has a blood clot go across a PFO once, they're at risk for having that happen again. So we close PFOs in people who have had an event, people who've had a stroke. Right? If you come to me and you've had a stroke and I can't find another cause for your stroke, I will close your PFO. But there's no proven benefit to just closing PFOs. What if there are 40 of us in the room, 10 of us have PFOs, but unless you've had a stroke, we're not going to benefit you by closing it.
Thank you. The next question comes from the aspect of research trials, and the question is, are these trial devices being used on patients at Bay State Medical Center? Yes,
very much so. So we're very fortunate that we're able to offer kind of the latest cutting-edge technology at Bay State. At many centers, you can get the latest thing that's commercially available. At Bay State, we're fortunate that we can offer not only the latest thing that's commercially available, but also the things that aren't yet commercially available that are in trials. And so that's really, I think, an exciting advantage because you get new stuff sooner, which may offer better therapies.
Next question is on aortic valve devices. And the question is, in aortic valve devices, do the leaflets just respond to blood flow? In other words, this is physics that makes the leaflets open and not an electrical connection within the device.
Yeah, it's purely mechanical. The leaflets are pocket-shaped. So if you think about, let's say, a if you take a bathing suit, right? Well, I wear a bathing suit that has pockets. So I guess some people don't, but if you swim with a bathing suit that has pockets, your pockets fill with water, right? But if you pencil dive, your pockets don't fill with water because the water is coming the opposite direction. So that's the way an aortic valve prosthesis works and the way a native aortic valve works, right? When the blood is being squeezed by the heart, it pushes the valve open, and then when the heart relaxes, blood pressure opens those pockets and pushes the valve closed.
The next question is around allergies, and do we test for any allergies before using these transcatheter devices?
Yeah, so we do not routinely test for allergies. The only real concern, and it's exceedingly rare, would be nickel allergy, but nickel is super common. So if you wear a ring, wear a watch, wear an earring, wear a belt, and don't have a life-threatening anaphylactic reaction, you're going to do fine with all these devices. If you really do have that issue, right, if you really do have that hypersensitivity, then it's important to discuss that, to review what components are in the device. And some of these devices are nickel-free, and some do contain nickel. For example, in the aortic valves, right, one is an alloy of nickel and titanium, the other is an alloy of cobalt and chromium. So that would be a reason to choose one over the other, depending on that. But if you don't have a significant hypersensitivity to nickel, and honestly, in the world in which we live, you would know that because every metal object you touch contains some nickel. If you don't have a significant hypersensitivity, there's no reason to test.
Just one last question from the audience.
Is there a difference between a heart flutter and atrial fibrillation?
Yeah, so it's a great question. Yes, so there are a couple of different atrial arrhythmias. Often they coexist, so people who have flutter may have fibrillation as well, but fibrillation means that there are lots and lots of abnormal circuits. Flutter usually means that there's one abnormal circuit. So that in somebody who has flutter, there's the overall normal electrical current, and then there's one additional abnormal circuit, which usually is in the same place. It's usually right next to the tricuspid valve. And so in somebody with flutter, there's the same stroke risk as there is with atrial fibrillation, and you need either a blood thinner or a left atrial appendage device. But flutter is much easier to ablate because there's only one circuit to try to get rid of, not 1,000.
Couple more questions online.
Please.
This question comes in. The doctor is suggesting a nuclear stress test. Is this something I should be worried about?
Okay. So obviously, that's somebody's individual personal clinical situation. Nuclear stress tests are fantastic screening tests or diagnostic tests to figure out whether somebody's chest pain or shortness of breath is coming from blockages in the coronary arteries. But I can't speak to anybody's specific medical condition here. But hopefully you're seeing an internist or a cardiologist to discuss that.
Another question that just asks about prerequisites for the left atrial appendage.
Yeah. So if you have atrial fibrillation and you're at risk of having a stroke, historically the first line of therapy has always been blood thinners. And then if you can't take a blood thinner, you don't need to try it, but if you can't take a blood thinner for some reason, if you have a reason not to take a blood thinner, right? I have a history of nosebleeds, I like to drive my motorcycle, whatever it is, then you would head for a plug, and then you would never need a blood thinner again. There are two major ongoing trials looking at people who have no particular reason not to take a blood thinner, but just don't want to. And so those trials are ongoing. I would expect that we'll have results in about 18 months. In that regard, and then I would expect that the FDA would approve those devices for people with no reason at all. Anecdotally, almost nobody has no reason at all, right? If people come to you and they say, I'd really like to get off my blood thinner, I'd like a left atrial appendage occlusion device, and you say, why? Almost everybody has an answer for that, right? I have, a bleeding problem, or, I've been tripping on my stairs. Usually people do have some rationale, and then you can kind of work through with them risks and benefits. But I think it's pretty rare to come across somebody who has absolutely no rationale for making that request.
Thank you. I believe we have our last question, which is, can you perform TAVR after having a mechanical aortic valve?
No. So a mechanical valve is two metal discs, and so there's no way to put a TAVR valve and kind of break those or bend them to the side. But the good news is that you shouldn't need to, because as we said, a mechanical valve is forever, right? Should last 10,000 years. So once you have a mechanical valve placed surgically, the downside is you need open heart surgery. The upside is it's a one and done. It shouldn't wear out.
I'd just like to say one last thank you to Dr. Goldsweig and a round of applause again for your wonderful and informative topic. Thank you very much.
Thanks so much for having me. And if folks have further questions, you want to talk about devices, I'll hang out for a little bit.